Good morning, ladies and gentlemen. Welcome to the presidential lectures of this Congress. You know that every year we have one session where we have established and well-known researchers receiving an award and young lecturers being tied together in one session, and they present for this year one of the outstanding features of this Congress. Just to remind you, you should switch off your mobile phones, and photography is not allowed in these sessions. And we will start immediately with the first lecture, which is Professor Andrew Lees from the National Hospital of Neurology and Neurosurgery. He will receive the Stanley Fahn Award, and that is an award that is created to recognize an outstanding scholar and role model clinician in the field of movement disorders. Professor Lees has done a lot of influential work in the field, and particularly in the field of clinical pathological relations. He has been the movement disorder president from 2004 to 2006. He was the co-editor of our journal between 1995 and 2003, and after all this lengthy introduction, I'm really happy to have you here for your talk on the Edgelands of Parkinson's disease.
Thank you, Gunther. Thank you, Matt. Ladies and gentlemen. In 1978, as a young fellow, my mentor and guru, Dr. Gerald Stern, wisely sent me on a pilgrimage to Spanish Harlem to visit Stanley Fahn. And that was the first time I met Stan, and he looked a little bit like the picture that you see behind you. I was ushered into his office, and within a few minutes, Stan arrived carrying a huge tripod and a video camera, and enthusing immediately to me, as if I'd been a friend of his for years, about a very interesting patient that he'd just seen in clinic. He then told me something that has served me in good stead ever since, which is that when you're looking at a movement disorder which is generalized, look at each body part separately rather than looking at the movement disorder in its entirety. And I've remembered this throughout my career, and it was the very first lesson I learned from Stan. Of course, I've learnt many other lessons from Stan as I've got to know him better over the years. But I would like to really single out amongst his outstanding achievements in movement disorders his work on the phenomenology of the dystonias and the tardive movement disorders. This is only part of his achievements, of course. Perhaps more importantly than his clinical writings is the students and fellows that he's brought through. He's created a school of movement disorders at Columbia. And those of you who know him well will know that he is a man of great personal warmth, generosity, and impeccable integrity. And those are some of the characters that I've come to admire about Stan over the years. And of course, without Stan's administrative skills, you wouldn't all be here today. The Movement Disorders Society was founded by Stan, and the journal, which you see on the first slide, was also his brainchild, along with David Marsden. Now, this accolade which the Movement Disorders Society has bestowed on me also provides me the opportunity to honor the many collaborators and fellows who continue to inspire me in my work and have constituted in no small way to the data that I'm going to present to you today. But I would like to start really by honoring the two hospitals where I've worked for the last 30 years, University College Hospital and Queen Square. And when I arrived at Queen Square as a young resident, it was like entering the Valley of the Kings. But through the oral tradition of my teachers, some of the pharaohs seemed to come alive. And amongst those, perhaps that ornament of British neurology, William Gowers, was the most illuminating. And I will talk about Gowers' achievements and his relevance to movement disorders as I go through my talk. Now, as a young man at University College Hospital, where William Gowers in 1860 joined the London Medical Society of Observation. There were many small learned societies in Victorian London, but this one was designed particularly to improve the accuracy of clinical observation. Gowers believed that if you observed carefully, you could see things that other people couldn't see. And he was a great botanizer as a medical student. He was also renowned for his excellent memory and he had a habit of producing accurate and instantaneous imprinting, which could be achieved through his memoir would harden and become as infallible as a photograph. He believed that the brain could be trained to improve its ability to retain memories, and that writing new facts down helped consolidation. In fact, he subscribed to Carlyle's view that genius is an infinite capacity for taking pains, and of course Stan is a very good example of taking pains in his everyday work. So Gowers' attachment to this society of observation was, I think, very important in his subsequent achievements. And like Stan, he had a secret weapon. Stan's secret weapon was a video camera, which we all use today and which I'm going to, through video recording, show you a lot of today. Gowers' secret weapon was Pitman's shorthand, which of course is now almost extinct with the advent of dictaphones and all the other ways of recording. But Gowers also anticipated the computer. And in the decade where he started to practice neurology, semiotics, a model based on the interpretation of signs to overcome diagnostic uncertainty, was becoming increasingly influential in the field of medicine. It's the ability to reason backwards, and Gowers became a master at it. And when I started at Queen Square, I was recommended to read Sherlock Holmes and read the complete works of Sherlock Holmes. At the time, I didn't understand what I was being told to do, but 20 years later, I certainly do. It helps your abductive reasoning powers, which are critical to being a good doctor, particularly in movement disorders. Now, with Bill Gibb in the 1980s, we tried to bring together what is known about the pathology of Parkinson's disease and correlate it with the clinical pictures. And of course, the only sign that is present in every patient with Parkinson's disease is bradykinesia. And we defined bradykinesia in 1988 as a slowness of initiation of voluntary movement with a progressive reduction of speed and amplitude of repetitive actions. This is different from akinesia, although it's closely related, and akinesia is an inability to initiate movement. So the slow psychomotor hangdog appearance of patients with Parkinson's, the facial hypomimia, the reduction of arm swing, these are often attributed to akinesia. But these are very subjective, and they're closely linked with psychomotor retardation and slowed reaction times. They're also subjective in the sense that for an Italian, all English people would be hypomimic, for example. So there is a subjective judgment about that. Hypokinesia, the other term that's often used synonymously with bradykinesia, is usually used to mean reduced amplitude. But of course, we often use these synonymously in our everyday practice. And when we made these criteria, I didn't really realize how important it became to emphasize this so-called sequence effect of motor decrement, which really characterizes Parkinson's disease. And I'd like to show you in this first video an example of bradykinesia. This is a patient with Parkinson's disease, and I hope you can see the reduced starting size of the movement. There's also reduced force, and then a delayed and progressive reduction in speed and amplitude of sequential finger movements. Patients with Parkinson's disease, of course, also have difficulty in doing two movements at once, but that's not really shown here on the video clip. So I really want you to focus on the reduction in amplitude of the picture. Now, there are many other causes of bradykinesia, and if you use the Unified Parkinson's Disease Rating Scale indiscriminately, you can get very high scores with things like amyotrophic lateral sclerosis. So if you don't know what bradykinesia is, then you're in trouble. And these are a couple of examples. One of them's from a patient Neil Quinn and I got got wrong, but let's just show you this one first. This is, so this is pyramidal slowness. They start moving immediately, but the movements are big, but very, very slow. And sometimes these patients come to movement disorder clinics with a diagnosis of multiple system atrophy, and then as further examination occurs, it becomes clear that they have amyotrophic lateral sclerosis. Now, of course, the two diseases can occur together, and Stan Fahn has described cases of that, but there is a possibility of confusion of pyramidal slowness and bradykinesia. Now, this is my first entry into the Edgelands, the title of my talk, and a conflict of paradigms. In 1990, with psychiatrists from the Maudsley Hospital, we studied a rare group of patients with obsessional slowness. These patients take hours to get dressed in the morning. They check continuously, but sometimes they don't always check, and the movement disorder that I'm going to show you is not due to checking. They have a delay in initiation, they have difficulty switching, they have motor perseveration, and they find it very difficult to do more than 2 movements simultaneously. Functional imaging that we carried out with Richard Frakowiak at the PET unit at the Hammersmith showed hypermetabolism in the orbital frontal and premotor and midfrontal cortex, and the fluorodopa uptake in these patients is, of course, completely normal. So this is the patient, and what I'd like you to try and see is this is not dyspraxia. This patient is not dyspraxic. The patient just takes a very long time to initiate. But once he starts, he's fine. So another kind of bradykinesia, if you like. Now, ever since I've been looking at patients with PSP, and there'll be many of you in the audience who have had similar observations, it's always struck me that the movement disorder of the hands in PSP is not really the same as the movement disorder that we see in Parkinson's disease, and yet PSP is one of the atypical causes of Parkinsonism. But careful observation of the finger movements suggests that there are differences, and of course, I can tell you that, but we need to try and prove it to you, and this is where the help of Brian Day and Peter Brown in the Sobel unit at Queen Square came to my rescue, and this was work done by Helen Ling, one of my clinical fellows at the moment. So this is the setup, and it'll be familiar to some of you in the audience. It's a 3D motion capture technique, and you stick infrared diodes over the back of the digits in strategic places, and you can measure speed of finger taps, amplitude of finger taps, duration of finger taps, and you can look at the slope, make slope calculations. So the patient is instructed to tap the index and thumb as wide and fast as he or she can after a buzzer which goes, and then for 15 seconds. And one important point when you're testing for fine finger movements is it's no good just doing 4 taps. You need at least 10 seconds of tapping and no more than 20 seconds of tapping, because after 20 seconds, a normal person starts to fatigue. So you can record the tap number, the amplitude, the maximum opening angle, and you can look at decrement and fatigue. And we did this study with a group of PSP patients, a group of Parkinson's disease patients on and off, and a group of normal controls. And this is just to show you the setup, really, of the system, and you can see, those of you perhaps who are close on can see the decrement, the sequence effect occurring on the trace to the right. The most important finding, and the one I want to stress in this study, is that these patients developed that the patients with PSP had a marked reduction of amplitude throughout the test compared with the other groups, and that this did not decrement. There was no decrement at all, so no slope. So this was small movements, but no sequence effect and no motor arrests. And this was really the main finding of the paper. So I'll just show you this. This is a patient with PSP, and I guarantee that if you look at your patients carefully in the clinic, you will begin to detect differences in the fine finger movements in PSP. So just watch this lady's fingers now. Little small taps. And that's what you get in PSP, in most patients with PSP. Sometimes there's no rigidity too. Often there is, but sometimes there is no rigidity. So it's different. Why it's different is a story for another day. And you can also see that in the handwriting. We backed up our work with some careful handwriting analysis. At the top of this slide, you'll see the characteristic right-handed handwriting of a patient with Parkinson's disease, sloping upwards, dilapidated script, which gets more and more crabby as the patient continues to write. And then after L-DOPA, the speed and amplitude of the script improves, but there is still a decrement and a reduction in size as the patient goes on writing. And then right at the bottom, you see this very classical microscopic micrographia, which you see in a few patients, but not all patients with PSP. This is fast, and it's incredibly small. You need a hand lens to read it, just to show you one of these patients writing. So patients with PSP have much more micrographia generally than patients with PD, but it doesn't correlate very well in either group with the finger movements. Now to switch tack a little bit and show you another patient where finger movements are very important. This was a patient seen in an eminent centre of excellence in another city in England who had been diagnosed with Parkinson's disease 5 years before I saw him. He'd been started on Madapar at low doses, and he told me when he came into the room that he'd hardly changed, and he wasn't much bothered by his tremor. He said he could do everything, everything was fine, and really he had no problem. So I'll just show you his walking. So he walks with a stooped, slightly reduced steppage gait, doesn't swing his arms, and you'll see a tremor in his right hand at rest and on walking. When you examine him, he has rigidity in the right arm, and those were the symptoms really that made the physician in the other hospital suspect he had Parkinson's. No arm swing, flexed posture, reduced steppage gait, a tremor which is present at rest, but he doesn't in fact have a delayed emergent tremor. The tremor comes out as soon as he holds his hand out. I haven't shown you that, but anyway, he doesn't. And then you do his finger movements, and I defy any of you to see a decrement. He has nice big finger movements. So although retracting a diagnosis that an eminent colleague has made is always risky, I felt unhappy about saying that this patient had got Parkinson's disease. And I conveyed this to him. And then I went to the Bible, as we do at Queen Square, the Manual of the Diseases of the Nervous System, written by Gowers in the 19th century. And this is what Gowers in his Borderlands, Borderlands of Epilepsy, of course, which is different from the Edgelands that I'm talking to you about. This is what Gowers wrote. Senile tremor often commences on both sides. Paralysis agitans almost always on one. There is not, however, any sharp demarcation between the two affections, and it is difficult to say in which category some cases should be placed. As already stated, it is doubtful whether the senile tremor is essentially different from paralysis agitans. Some cases are met with of a character intermediate between the two affections. That's what I think we've got here. But Gowers didn't have a DAT scan. Of course, many of us now have easy access to dopamine transporter functional imaging. My patient that I've just shown you had a normal DAT scan. I was able to stop his Madapar, reassure him he had Parkinson's disease, that he didn't have Parkinson's disease, and he's remained the same as we've gone on following him. So another example of careful attention to fine finger movements. It's a very important test for us in movement disorders. Now, going back to the work that Helen Ling did, as well as the PSP findings, we were also able to confirm findings that other people have already confirmed by looking at slope of change in amplitude to assess progressive hyperkinesia or decrement. And what you see is that L-DOPA improves speed and probably amplitude, but it doesn't improve decrement. And what you need to improve decrement are things like this study by Bob Jansek, who spent some time at University College London hospitals during his training. So this is a lady of Bob's who had freezing and festination and as a consequence falls, showing you that the only thing which gets rid of the sequence effect and the decrement that's been shown clearly is visual, possibly also auditory cueing. Maybe music can also get rid of the decrement too. So this is possibly non-dopaminergic, but different. So if you don't expect L-DOPA to get rid of the decrement. Now the Edgelands, many of my English colleagues anyway have asked me what the Edgelands are, and I've borrowed this from two wonderful poets from the northwest of England, where both John Hardy and I come from, Paul Farley from Liverpool and Michael Simmons Roberts from Preston. Those of you who like poetry, I would recommend that you read their work. And what I'm talking about with the Edgelands are the margins where the rules of neurology do not apply. These are the brownfield sites between houses in cities where children play and make dens. It's a place where neurology and psychiatry renegotiate their boundaries. It's a sort of no man's land between two fiefdoms, and of course it gives you a kind of freedom because you can escape from the rules of our speciality. So now I'm going to enter in the world of fantasy for the last 10 minutes. So fear, and this is what Gowers had to write about fear in 1904. The influence of fear is indeed the only fact in the causation that can be called intelligible. Its direct effect is on the motor centers to induce the movement necessary for escape, which seems to have made the term movement from a name for all such peculiar mental states. If that movement be impossible, tremor results, and thus we have the word to tremble as a synonym for fear. He who trembles is said to be paralyzed by fear, and he is in fact for the moment suffering from paralysis agitans. This is our former Prime Minister. We could have the sound up a bit.
Isn't it amazing? When it comes to real policy, when it comes to discussing the long-term future of this country, he is not even in a comes to real policy. When it comes to discussing the long-term future of this country, he is not even in a comes to real policy. When it comes to discussing the long-term future of this country, he is not.
So, and there were concerns about Gordon Brown's health at that time. He's much better now. He's out of office. So I'm not suggesting for 1 minute that the tremor you saw is a tremor of Parkinson's disease, and of course it's not pill rolling. But this just illustrates what Gowers says, that there is this release of catecholamines can create a superficial similarity to some of the features that we associate with Parkinson's disease. And of course, the time when you release most catecholamines is when you're frightened. And perhaps one of the most frightening experiences the world has ever known were the soldiers who had to fight in World War I. And there's a wonderful literature of war neurosis. Of course, many of these cases are psychogenic movement disorders. In fact, the large majority are psychogenic movement disorders. But some of the leading neurologists of the beginning of the 20th century got very interested in this. Amongst them was Sir Frederick Mort. who wrote another form of tremor which is coarser and less rapid than the preceding is a 5 to 6 cycles per second, which resembles paralysis agitans. Now, I'd like to show, and there, as well as the literature, there is a wonderful archive of filming of shell shock cases held in the Pathé News film archive, which is open to everybody. And I want you to just look at this soldier, not the first one, but the one coming next. Not him. This one now. This one. He's got a shaking hand, and he doesn't shake his right, he moves his right hand. Which brings me to recovered Parkinsonism. I've seen in my career, two patients who had not been exposed to toxins, neuroleptic drugs, infection, who have recovered. Both of them needed L-DOPA. Both of them had Parkinson's disease for several years. The first was a lady who had been under intolerable stress through her marriage, and when she divorced her husband, she recovered. And the handwriting that you see at the top of this slide is her when she had Parkinson's disease and was responding to L-DOPA. And the handwriting later on, a few years later, which I hope you will accept is much larger, is when she got better. And these two cases, the other lady had had open heart surgery and developed these symptoms afterwards, and then got better gradually over several years. And these two cases have haunted me because, of course, none of us really believe that Parkinson's disease can get better, although it may go underground for a few weeks and then come back. And this PET scan, which you see here, is, unfortunately, we couldn't do one when she was recovered, but it shows a fluorodopa uptake intermediate between normal and Parkinson's disease in one of the cases. Ray Kennedy, the distinguished Arsenal, Liverpool and England football player, taught me so much about Parkinson's disease. Athletes are very aware of their body movements, and he really was absolutely adamant that he had subtle transient motor disturbances going back for several years, in fact 7 years, before the onset of, or the diagnosis of his Parkinson's disease, so while he was still playing. And some of the things he highlighted were episodic stiffness of the limb, transient freezing, not when he was playing football, I should add, he was fine when he was playing football, and inner feelings of tremor. And of course, linked with the blocking and the freezing is kinesia paradoxica. And if we want to understand bradykinesia, we have to also understand kinesia paradoxica. And perhaps Ray was able to play well because he was rewarded by playing football. And I'd like to show you this very brief video of a patient who liked money, was very driven by money, and this is the carrot test, which some of you who are interested in impulse control disorders will know about. It's a test of monetary reward responsivity. And I want to show you this patient who could switch himself on by doing the carrot test. So the rewards from the carrot test could switch him from off to on consistently, and also give him dyskinesias with no extra medication. So just watch this clip quickly. So you'll hear money going down later. So this is him before he's got to sort these cards out. And in a second, you'll see the rewards. This is Andrew Evans did all this work when he was with us now back in Melbourne. So this is rewarded now. You'll hear Andrew. So as the money goes down, he gets faster, movements get quicker. What this tells us really is that patients with Parkinson's disease lack motivational vigor, and that they can achieve similar speeds and accuracy of reaching movements, but they do it much more rarely than normal people. There's a reluctance to move, which can be stimulated by reward. So Some of this kinesia paradoxica mechanism may also be dopaminergic through the ventral striatum, cross-sensitization to the dorsal striatum. So it may not all be non-dopaminergic. There may be ways of stimulating movement either by fear of punishment or by reward that can also be very useful in our therapeutic strategies to help the disease. Now, this is a patient who actually used this technique to keep switching on. He also was driven by money and had started to use slot machines. And by using slot machines, he could prevent himself from switching off. In the video, you will see him in an off state. And what I want you to see is the striking waxy flexibility, which is really, if a psychiatrist was to see this patient, they would diagnose him as having catalepsy and possibly catatonic schizophrenia, but he has Parkinson's disease, and if you put his arm like this, he'll hold it in this position until it's moved or he switches on. And this patient is perhaps one of the best examples that we've seen really of rewarding through being used by patients through punding to switch people on. Now, the last couple of slides, I want to go even deeper into the Edgelands and talk about the very nebulous concept of chronic stress as a possible cause for Parkinson's disease. This, of course, is not new. Charcot and Gowers, too, were both very impressed by the possibility that chronic stress as opposed to acute stress could damage the system, whatever the cause of the damage was, and lead to Parkinson's disease. And those of you who are interested in non-motor symptoms, either as an important component of Parkinson's disease or as part of the prodrome, need to get very interested in the functional somatic syndromes. These constitute at least 10% of referrals to primary healthcare physicians. The three most important ones all have a peak incidence in the 30s and 40s, fibromyalgia, chronic fatigue syndrome, and irritable bowel syndrome. And many of the features that these patients suffer from are those that are reported in the prodrome before patients develop Parkinson's disease. And the further you go into the literature, the more interesting it gets, because there's quite a lot of work being done on autonomic dysregulation in these three syndromes, which I think are very closely linked together and may not be different, actually. There's also evidence of dopaminergic dysfunction and changes in the striatothalamo-cortical loops. So could it be that patients who have functional somatic syndromes are perhaps at slightly greater risk of developing Parkinson's disease? All of these three conditions have been linked with anxiety and depression, of course, as well, which I've been talking about. And this bit just shows you the links and the overlaps between functional somatic syndromes and Parkinson's disease. So I finish with a slide that has served me well over my career. I show it many times, and I apologize for those who've seen it, but I think it epitomizes what a neurologist, even in the 21st century, should be. And it was given to me by MacDonald Critchley, one of my teachers, adapted from a quote originally by Francis Bacon. So I'll finish by just reading it to you, if I may. The men of experiment are like an ant, they only collect and use. The reasoners resemble spiders who make cobwebs out of their own substance. But the bee takes a middle course. It gathers its material from the flowers of the garden and the field, but transforms and digests it by a power of its own. Not unlike this is the true business of neurology. Thank you very much.